Hi, this is Elliot Fishman, and let's go to part 3 of CT evaluation of liver masses, key differential diagnosis and pathways. We left off previously talking about FNH, its characteristic appearance, the feeding vessels, the lesion homogeneity, becoming isodense over time, some of the unusual features including the fact that sometimes it's pedunculated. What about hepatic adenomas? Usually when you say FNH, the next thing you say is hepatic adenomas. Hepatic adenomas are more common in women, mean age in their 40s. There's a strong relationship between long-term oral contraceptive use and hepatic adenomas. There's an increased risk of anabolic androgen steroid intake, as well as metabolic liver disease such as glycogen storage disease, tyrosinemia, steatohepatitis, and hemochromatosis. So those are things we also will consider leading to hepatic adenomas. The majority of hepatic adenomas are solitary, but they can be multiple. They're particularly commonly multiple in things like glycogen storage disease, range in size between 1 and 15 centimeters. The big issue with hepatic adenomas, it's the classic lesion to spontaneously bleed. We'll talk about lesions that bleed from hepatomas to hemangiomas, to hepatic adenomas, to infection, but at the end of the day, hepatic adenomas is always at the top of the list. And then, of course, the potential for hepatic adenomas to develop into hepatomas. If you ask me to describe hepatic adenomas, we talk about classic appearance and then the range of variability. Typically, it's a well-defined mass that may contain hemorrhage, necrosis, fat, or rarely calcification. There aren't too many tumors that contain fat, myelolipomas in the liver or angiomyolipomas. We can see that with hepatoma, but hepatic adenoma is one of them. Typically, it's hypodense or isodense on non-contrast scans, though you often will see a mass effect when they're larger. There's moderate arterial enhancement. There's the lesions enhance similar to surrounding liver and tend to begin to become isodense on the portal phase imaging, and on delayed phase imaging will commonly be isodense unless there's areas of central necrosis or bleeding within the lesion. Here's an example of a vascular lesion right lobe of liver. You can see prominent vessels going to it. It doesn't look like hemangioma. You could think about FNH, but the vessels are not that central vessel. It's enhancing, but not as homogeneous as we would like. But you still could think about FNH. It's a possibility. You could think about hepatoma, though the liver is not cirrhotic. You could think about metastasis. But you got to be thinking about hepatic adenoma. Vascular lesion, feeding vessels, increased vascularity, no underlying cirrhosis. On venous phase, the lesion is still seen, though beginning to become isodense. That's an unusual case because it's small. Here's another patient, 40-ish-year-old female, vascular lesion, mass effect pushing toward the IVC. You can see some of the vessels feeding the lesion. It's bright, it's irregular. Could think about FNH, but not as homogeneous typically as an FNH. You got to think hepatic adenoma, but truthfully, you're also thinking something like hepatoma. Here's the lesion again on venous phase imaging, very vascular, fairly well defined. It looks solitary. There's no underlying cirrhosis. So again, you're going through that differential diagnosis. Here it is nicely shown with the mass effect on the cinematic rendering. Classic hepatic adenoma, but not so easy because I would be thinking of hepatoma all the time. It's not just a leave-alone lesion. Here's another case, mass left lobe of liver. It's kind of subtle, right? There's increased vascularity, but not as bright as we see with the classic hepatic adenomas, or not as bright as FNH or most lesions. It kind of looks like a funny-looking enhancement pattern. It's kind of subtle. You can see the same subtle changes, maybe a little more obvious perhaps, as you go to the coronal display. And as you go to the MIP imaging, the vascularity as well as the stretching of the hepatic arteries is better seen. And what you can see in this case is a hepatic adenoma looking not so much like a mass, but more like an infiltrating lesion. It's infiltrating and stretching the vessels. And then as you go to the excretory phase, about 5 minutes out, you can see that there's a bulge around where the lesion is, but it's essentially isodense. And that's a very good example of hepatic adenoma. Here's the isodensity also showing you nicely on the coronal views, but you can see the mass effect. There is a mass there on the patient's lesser curvature of the stomach. And cinematic rendering, which is really good at looking at texture mapping, shows you really nicely the textural changes of that mass. In fact, it makes the mass stand out, perhaps a little bit better than it did on the routine CT scans. And one of the things we like about cinematic rendering is accentuating texture mapping, which it does in this case. Another patient. Here we see multiple small vascular lesions. Could it be metastasis? Doesn't look like hemangiomas. Patient has fatty infiltration of the liver with multiple small vascular lesions. Better seen on the MIP. We said that up to 80% of hepatic adenomas are going to be solitary, but they can be multiple. We said it's more common with glycogen storage disease. It's also more common in patients who have fatty infiltration of the liver. Mike Federle wrote articles about that. And you can see as you go to venous, the lesions stand out nicely. Multiple lesions. And again, Mets are in the category. Unusual hemangiomas. I know hemangiomas can be multiple, but it really doesn't look like hemangiomas. Hematomas really doesn't look like. Look how impressive it is on the cinematic rendering. I would be thinking really hard of metastatic disease. Here's some more with the vessels accentuated on the cinematic rendering, and these were multiple hepatic adenomas. So I think one of the things I'm trying to show you is hepatic adenomas are much more challenging, where the majority of FNHs have a classic appearance. Hepatic adenomas can be atypical in this multiple appearance, can be infiltrative rather than mass-like or simulating infiltration while there's still a solid mass, and can look very much like a case of hepatoma. Another example, vascular lesion, arterial and venous phase imaging. This lesion, the liver texture is a bit irregular. I would worry about a vascular hepatoma here. Could also consider cholangiocarcinoma, though the vascularity pushes me more to hepatoma. This was hepatic adenoma. You see the feeding vessels. The vessels are kind of stretched. The lesion is very vascular. You can see it here again. It does become a little bit less obvious, though still very obvious, on venous phase imaging. But again, I'm thinking hepatoma first, cholangiocarcinoma second, maybe metastasis, and this was a hepatic adenoma. And it's good to say that it can be difficult to distinguish hepatic adenomas from hepatoma based on CT criteria. There's no doubt about it. Now, we mentioned that one of the challenges of hepatic adenomas, they spontaneously bleed. Here's a patient with a large bleed in the liver. Obviously, bleed can be due to trauma, can be due to biopsy, but the classic lesion that bleeds is hepatic adenoma. Right behind it is going to be hepatoma. You can see the bleed, the mass effect, the stretching of the vessels. Often you don't really see the mass because the mass ruptures when it bleeds. But again, you would have to worry about this. Could be hepatoma, could be hepatic adenoma. The patient did not have a cirrhotic liver, and maybe that makes me feel better about hepatic adenoma. Another patient, right upper quadrant pain, big time bleed, mass effect, stretching of vessels. Here it is on venous phase imaging. You can see the bleed present. Hard to define specifically, again, the mass. As I mentioned, once a lesion bleeds and ruptures, the mass is poorly defined. We know the same thing to be true in adrenal glands when things bleed. You see the stretching of the vessels, but no neovascularity. And this ended up being a hepatic adenoma. Again, there's no way you could say that it was not a hepatoma. But you have to worry about hepatic adenoma just because it's the most common thing to bleed. When CT is not specific, MR is the next logical step. PET has been done, but really is not helpful. Most of the lesions will be positive on the PET scan. Very nicely here showing you the vascularity around the edge of the lesion, and on the cinematic rendering, the bleed, the mass effect, the irregularity of the surface of the tumor. Or another case, subcapsular bleed, intrahepatic bleed. Where's the lesion? Difficult to define. Again, you'd be thinking about hepatic adenoma, but I showed this case to make the point, just like I said a few moments ago, you can't really be definitive about hepatic adenoma because often the lesion is not seen once there's a bleed and then you worry about hepatoma. But as I mentioned, when I gave a differential for bleeding, it can also be the metastatic disease like neuroendocrine tumors, renal cell carcinoma are a couple examples. And this was a spontaneous bleed due to metastatic neuroendocrine tumor to the liver. So again, we like to push hepatic adenoma to the top of the list for hepatic bleeding, but it's not the only thing we need to think about, and it can be a very challenging diagnosis. Here you see multiple hepatic lesions. I guess the fact is multiple hepatic lesions, though one really dominant one, should make you really be thinking about metastatic disease, though multifocal hepatoma does occur. And I showed you a case of multifocal hepatic adenomas. Again, nicely shown on the coronal and in the 3D volume rendered views. In this article by Thomas, a broad spectrum of pathologic conditions can present as spontaneous hemorrhage within or surrounding the liver and may present acutely or as a chronic or incidental finding. Imaging characteristics and clinical history can often narrow the differential diagnosis and guide management. And here's just a list of the causing of bleeds, right? Hepatoma, hepatic adenoma, FNH, hemangiomas, METs. I just showed you a case of METs. I will admit hemangiomas are exceedingly rare. People show case reports. I think I've seen one. HELP syndrome, amyloidosis, connective tissue disease like polyarteritis nodosa, where you have a vasculitis type process, and occasionally from infectious diseases, but it's unusual infection, typhoid fever, and malaria. Key features that predispose a particular tumor to rupture include its location within the liver and its size. The highest risk tumors are large and within the periphery, either abutting or protruding beyond the capsule. The minimal thickness of peritumoral liver parenchyma and the degree of capsular protrusion both have been associated with increased risk of rupture. And that makes some sense. I'm not saying it's due to mild trauma, but anything near the surface, if things go wrong, you're going to see a large bleed. If it's more central in the liver, it's less likely to bleed. In this article, they also mentioned the cause of hemorrhage and hepatomas is likely multifactorial and not completely understood. Rupture may be facilitated by tumor angiogenesis, which increases as it mutates from a cirrhotic nodule to a dysplastic nodule to hepatoma. This leads to an increasing proportion of its vascular supply being derived from new, unpaired hepatic arteries, while diminishing contributions from the portal venous system. Microinjuries and elastin deposition in these small arteries may predispose to hemorrhage. Now that is very good science, but I will tell you it's not going to help me looking at a hepatoma saying I think this lesion has a chance of bleeding. So let's look at some examples. Large mass right lobe of liver, underlying cirrhosis, tumor is infiltrating. You can see the blood around the edge of the lesion. You can see the neovascularity within the lesion proper. Again, very nicely, the blood, the area of rupture, very nicely seen in this case. You see the neovascularity, you see the active bleeding, really nice example. And here it is on venous phase where you can see the tumor growing basically through the capsule of the liver and the bleeding going on around the patient's liver. It's also shown very nicely in that same example on the cinematic rendering, both planes. Again, very nicely showing you the mass, showing you the blood and disruption in the capsule of the patient's liver. Another example, vascular mass, right lobe of liver, lots of neovascularity. It does seem that the more vasculature there is present, the more likely are to see bleeding, feeding of vessels, the neovascularity, all of it very well defined. In this case, I think the fact the lesion is so well defined is going to be less likely going to bleed over time, but I don't think we ever make that judgment or ever make that conversation. I do like, again, the cinematics showing you the very well-defined capsule of the liver, the relationship of the tumor to the capsule, and the relationship of the tumor itself being very well defined. Now, I mentioned about hepatomas arising from hepatic adenomas. Here was a patient developing a hepatoma in hepatic adenoma. The patient also presented, their initial presentation was a spontaneous bleed. You can see the stretching of the vessels. You can see some of the suspected neovascularity. Here it is on venous phase imaging where you see the mass, the blood. If I said to you this was only hepatic adenoma, I think it would be hard for you to say this wasn't only hepatic adenoma. But once it bleeds, once it's irregular like this, you have to really worry, could you be dealing with a hepatoma? And eventually this was resected, which is the way you manage surely solitary hepatic adenomas that have bled. And this was a hepatoma on pathology, really nicely showing you the mass effect on the veins. Another example. So one of the things to mention, we talk about cirrhosis, we talk about hepatic adenoma and the transition from hepatic adenoma to hepatoma. It's important also to be thinking about hepatoma all the time. When I see any vascular lesion within a cirrhotic liver, you got to make certain it's not hepatoma. Yes, you can say the lesion is only 1 centimeter, but as I mentioned, hepatic adenomas can start small, and when you pick them up early, you can resect them. Remember, we're not thinking about hemangiomas when we're talking about cirrhotic liver. So here's about a 2 centimeter mass near the caudate lobe and right lobe of the liver. You can see it nicely there. This patient had hepatitis C. Again, what else could it be? Regenerating nodules, a thought, but usually they're multiple. Could it be metastasis? Could it be hepatic adenoma? But when I'm thinking about cirrhosis, I'm really thinking about hepatoma. And here you see the vascularity going to the lesion. That really makes me worry about hepatoma. In this example, you can see on the venous side the large varices from portal hypertension, but also the extension and involvement of the portal vein. Very important to recognize that portal vein extension is very common with hepatoma. Now, we also know that one of the concerns we have these days is NASH, that hepatomas are more common in patients with NASH. And here's a good example, diffuse fatty infiltration of the liver. At first glance, you almost could miss this mass that's sitting here. It's better shown on the venous than on the arterial phase. You could see it when you see a vascular lesion in the patient with fatty liver and NASH. You got to be thinking about hepatoma. The lesion nearly becomes isodense, but I still can see the lesion pretty well. And here it is in the coronal view, also very nicely shown. Now, in terms of hepatoma, abdominal pain is one of the presentations. Obviously, maybe it's due to a bleed, but not always. Here's a large mass in the liver. Now, I've shown you a bunch of hepatomas, and I'm going to show you a number of additional hepatomas, because hepatomas have a range of appearances. In this case, there's a mass present. It could be a met, it could be a cholangio, it could be hepatoma. It's infiltrating, but mass-like, doesn't have extensive neovascularity. There's some vascularity present, but it's relatively hypovascular. You can see as you go from arterial to venous phase imaging, the borders of the lesion are a bit better shown. You can see it very nicely here on the cinematic rendering. And this is a case of hepatocellular carcinoma. Again, very nicely shown across the spectrum of imaging. Another mass, left lobe of liver, again relatively hypervascular at the periphery, and perfusion changes seen at the periphery, though the dominant component of the mass is irregular but not very vascular. You can see stretching of the hepatic artery, the suggestion of some neovascularity. You could see it on the venous phase imaging. Could this be cholangio? It doesn't quite look like cholangio. It doesn't look like hepatic cyst, doesn't look like hepatic adenoma, FNH. Could be a cystic metastasis. This was a hepatoma that for the most part was mainly cystic in nature, kind of a really challenging lesion. It's interesting how on the arterial phase it looks more solid, on the venous phase it looks more cystic. From the arterial phase with the vascularity around the periphery, I'm thinking hepatoma versus cholangiocarcinoma. Another example, elevated liver function tests, large mass right lobe of liver, well-defined on venous phase imaging. Just like the last case, suspicious for malignancy, hepatoma versus cholangio. Mets could be a distant third. This was a fibrolamellar hepatoma, which is a tumor that occurs in younger females, but it's a hepatoma nevertheless. Fibrolamellas are fairly aggressive. So when you think about hepatoma versus liver mets, without a clinical history of a primary tumor in the absence of cirrhosis, this can be especially challenging. Some metastases, just like HCC, can be very vascular, and these include mets from thyroid cancer, renal cell, and neuroendocrine tumors. So just seeing a vascular mass, we're always thinking hepatoma, but you need to be thinking about metastatic disease as well. And what I'll do is I'll stop here, and then we'll go back and look at a range of vascular lesions, distinguishing or trying to distinguish what's a hepatoma from what's a metastasis. So we'll come back in a few minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.